Dr. Rich Lindrooth, who is a professor in the Department of Health Systems Management and Policy. And he is an economist and is going to be presenting his work on accountable care organization, or accountable care collaboratives.
Yes,
accountable care collaboratives. And so he will be using some methods that Debashis introduced this morning related to propensity score, propensity weighting, and so forth. Our next panelist is Dr. Marian Dickinson, who is a professor in the Department of Biostatistics at the School of Public Health and is senior biostatistician at Accords. And she's involved in a number of projects. It provides a statistical guidance and expertise in a wide variety of projects related to big data. And finally, Dr. Nicole Carlson, who is an associate professor in the Department of Biostatistics in the Colorado School of Public Health and director of the Colorado Biostatistics Consortium. And her research interests involve models of driver response and feedback, Ford associations and biologic data, Bayesian models of pulsatile hormone data, point process models applied to biologic data, and hormone data and Alzheimer's research. So help me welcome our panelists. I should also say, Rich needs to catch a flight this afternoon, so I really appreciate that he's here. So each panelist will have a similar format, about 15 or so minutes, but questions for Rich will be right after his presentation, so he doesn't miss his flight.
Yeah, thank you, Beth. And it's funny, you almost call it accountable care organization. We did that in our initial proposal and got in trouble. And they quickly pointed out it's not an ACO. There are major differences. So Medicaid has called this effort the Accountable Care Collaborative, for the ACC's acronym I'll be using throughout. I'd like to acknowledge support from Colorado Health Foundation and the Rose Community Foundation for this research. Co-authors are Greg Tung and Tatiana Santos, the Sean O'Leary from Accords, and then Judy Zerza is the Chief Medical Office of Medicaid. So the primary goals of the collaborative, and these are stated in the literature that HCPF created to tell people about it. It's first generally to improve member health, improve the member and provider experience, and contain costs. They do this through there's several changes associated with the ACC that help them to achieve this goal. One is the formation of these regional coordinated care organizations, or care collaborative organizations, or called the RICOs. And so these are regionally based in that they're clusters of county. There's 7 of them throughout the state of Colorado. And so roughly if the beneficiary lives in a certain county, they would be assigned to an individual RICO. However, there are some cases where people travel out of their region and have a physician in another region, so they'd be in there. But generally, you can think of them as regionally based. And so these RICOs get a per member per month payment, so a per head payment from HCPF to help coordinate the care of Medicaid beneficiaries. And part of their task is to recruit and enroll primary care physicians to serve as medical homes for the beneficiaries. And so individual Medicaid beneficiaries that join the ACC are attached to a primary care medical provider through an attribution process that I'll explain a little bit more about in a bit. In turn, the PM also goes to the primary care medical providers, as well as bonus payments that are tied to key performance indicators. And then there's another element, which is kind of going on in the background, is they've contracted with a statewide data analytics contractor, or SDAC. And so this organization is helping with the attribution of enrollees to individual providers. They're also providing monthly reports on utilization, doing some benchmarking, and so forth. It's all claims database, so there is a lag between when the actual care is provided and when the reports are sent out. But that's the role of the SDAC. So we're going to focus, a part of what we were tasked with is understanding how the ACC is associated with changes in spending. So how much does it cost? So initially, HCPF is paying out money in terms of the per member per month capitated payments for case management. And so they were wondering, how does this affect study. Otherwise, without the PMPM, there were no significant changes in reimbursement. It continued to be fee-for-service. So the financial incentives of individual providers are largely unchanged, but for the key performance indicators. And so these are incentives based on utilization of the ED, high-cost imaging, whether or not there's a well-child visit, or 30-day readmissions. And so the performance on these measures is tracked and aggregated to the RICO level. And then if the RICO surpasses some benchmarks, then they receive a bonus payment, which they in turn give out some of it to the individual primary care providers. But keep in mind that it's based on group performance and not individual provider performance, which in turn lessens the strength of the incentive. So I'm going to get to understand that the focus of this is really on the on the methods and the approach we took to estimate these effects. So we got a sample of claims, and it's a universe of claims for people who were enrolled in Medicaid and were also eligible for the ACC. And the eligibility was based on whether or not they have third-party liability insurance, whether or not they're also eligible for Medicare, and so forth. The results I'll be presenting you are what I call the standard Medicaid enrollees, and it includes both adults and children. And so our approach is we're going to try to analyze the spending of the folks who enroll in the ACC as compared to the people who remain in fee-for-service. And there are a number of challenges of this. One is that people aren't randomly allocated to the ACC or fee-for-service. Instead, there's an enrollment process that we will argue does not confound the estimate on the ACC treatment effect. And I'll give you that argument in a second, but part of it is that it's only valid for the first cohort of enrollees. So we separated the group into people who began during the first fiscal year of the ACC, and then we separately look at a cohort that began the second year and third year. And the reason we do that is because the enrollment criteria changed over time. We have a pre-period, so for each cohort, we have at least 6 quarters of pre-period spending on individuals. And then we allow for an adjustment period. So when a person enrolls within the ACC, we exclude data on the quarter before and the quarter after enrollment. To be honest, if we included that, you see a consistent spike in utilization right upon enrollment that's due to increase in primary care visits and then anything they find. But then it levels off after that initial spike. And so we took that out to really get an idea of the longer run changes in spending and not just the initial spike in enrollment. And so we follow up people for up to 3 years or 12 quarters for cohort 1, and then it's shorter for the later cohorts due to the length of our sample period. So the unit of analysis is the individual person, the individual enrollee, and T is quarter. So we really aggregated the spending and utilization up to the quarter level. It's an unbalanced sample. So there are people who cycle on and off Medicaid throughout the time period. That's an additional challenge. And as I mentioned, we do have an exclusion based on the washout period. But also, if anyone has less than 3 months enrollment, we exclude them from the sample. So each of our quarters reflect a full 3 months. And then, for risk adjustment, we merged up what's called a chronic disability, chronic disease payment system. It's analogous to, say, the 3M risk adjusters and so forth, and that it looks at prior utilization and then identifies sets of comorbidities based on prior utilization. And so we have a 6-month look back period in order to risk adjust our outcomes. So, visually, this is how it's set up. We have this pre-period here. We have a washout period and then our post period. And so with the difference methodology, we compare the difference in spending in the pre-period between the ACC, which is our treatment group, and the control group, and also the difference in spending in the post period. And so the difference in differences measures the relative change in spending for the ACC population relative to the control group. And so it's pre-post, and then the pre-period, nobody's exposed to the ACC. In the post-period, only the ACC enrollees, are treated in terms of being in the ACC. And so, as I mentioned before, there's a selection process to get into the ACC. And during the first year, this was primarily done through physicians. So if a physician agreed to become a member of the ACC, then all the enrollees attributed to that physician defaulted in the ACC. So it wasn't a decision to enroll per se. The default option was ACC membership. And so, in thinking about this, we thought that the decision in part is based on the physician. So the physician would, evaluate what the BRICO is doing, what to expect from the ACC, and then join. And so all their beneficiaries would follow them. And so initially we approached this more as a physician decision. But then over time, the enrollment changed. So there were other avenues into the ACC. New people who first enter Medicaid were signed up for the ACC. And in the end, the only people who were not defaulted in the ACC were those who were attributed to a primary care provider who was not in the ACC, if that makes sense. So at the beginning, if your provider was in the ACC, you defaulted into it. By cohort 3, the only people who didn't default into it were those who were attributed to a non-participant. So it's kind of similar, the difference being during cohort 2 and cohort 3, people new to Medicaid would automatically be enrolled in the ACC. So in a sense, there's a slightly different selection mechanism over time. So to get at this enrollment decision by the physicians, we replicated the attribution algorithm that was used by the data analytics contractor and attributed everybody who could be attributed, so everybody who had utilization of evaluation and management visits, we attributed them to individual primary care physicians. And so we know, and some of those, as I mentioned before, were actually in the ACC, other ones weren't. And so we use that information as to who their primary care physician is as part of the estimation. And so, as I mentioned before, we had a difference analysis, but we also included a propensity score weighting to get at the selection, and we're arguing that it is selection on ability. And so we use information about the attributed provider, including the provider type. We also use information on the patients, the patient language, which we hypothesized would affect which physician they see and could potentially affect their overall utilization. We also use the risk adjustment and age to achieve balance on those variables. And so we weight the regressions using inverse probability weights, which are based on the propensity score. And the idea being it makes the treatment group look more similar, or excuse me, in this case, the control group look more similar to the treatment group. So a set of control group observations are very similar in their characteristics. The weight would be higher for those individuals. People in the control group who are dissimilar to the treated would be weighted lower in this comparison in the AT-ET type approach. So we also have churn, as I mentioned before. And so we use an approach that Elizabeth Stewart, a biostatistician, published in 2014, where we do a multinomial type propensity score. And so not only do we estimate it for the ACC versus the control group in the pre-period, because we have churn, We also estimated for the ACC group in the post period, and then the ACC group in the post period for the fee-for-service. And so we have this multi-dimensional type propensity score in order to ensure that we have balance of the covariates over time. And we're doing it based on quarters. And given the number of quarters we have quite a few estimates here for the propensity score. I actually talked through most of these variables. I won't go through it in detail, but in order to achieve balance as defined by the standardized differences for the variance ratios, we did include some interactions to get there. Initially, our balance was not that good, but then we used interactions until we found something that satisfied the standard criteria for balance. And we were able to get it pretty quick. This is actually one of the better looking overlap graphs. So what you want when you're using propensity scores is that you have this region in here where the treatment group, in this case, the setup would be this dotted line here is similar to the control group. So it's as though, regardless of what group you're in, you're similar in that your probability of getting the treatment. So you'd be nervous if the treatment group had a massive probability down here and the control group had a mass here, because that'd be a signal that there's something fundamentally different about the two groups. And so by including these interactions in our specifications, we found one where there's a reasonable amount of overlap. And this one actually looks good. Yes?
Sorry if this is a stupid question, but a lot of the people that are in the pre are in the post, right?
Yes.
So how are you dealing with that? What can you
measure? Yeah. So for that, so we do match and so the overlap is a lot better when we're matching over time, because many of the people are still in the program. And the only thing that's changing is their the risk adjustment variables, so their prior 6 months utilization. So those will change over time, but the other characteristics would be the same.
And it doesn't mess anything up. Some of them are, some of them aren't.
Yeah. So if they're identical, then essentially it's as though they're, that we haven't done anything. But this would adjust for any differences that do occur. Yeah. And I do have worse looking graphs. I feel bad about having this one up there, so it does look good. But there are some other ones that are skewed more. Yeah, this is a view of the standardized differences, and we see the weighted one and the unweighted ones are really the base case. And then when we apply the weighting, they look a lot more similar. And which is, the idea behind using the propensity scores to get the distribution of your X's more similar. You see across the board, it works pretty well. And so this is the graphs of our adjusted mean differences based on each cohort. And so in the top here, so we're plotting over time. I have these vertical bars representing the washout period. It's longer than 3/4 because some people are a little bit later. So, but this is kind of the average washout period. And we see, if we look at PMPM spending, the unadjusted means are right here in the fee-for-service group in blue. I don't know if you can see the colors actually. It's the one on the top here. We see that unadjusted, the trends are not parallel. And so one of the assumptions, if you will, of the difference approach is that you have parallel trends in the pre-period. And the reason for that is you're using your control group to approximate everything that's changing in the population over time. And so by having this control group and the parallel trends, we're in a sense assuming that those trends would continue absent the ACC. So that they'd be continue to be parallel if the ACC didn't exist. And so the level is less important than the trends, which in a sense we're projecting those into the future period. And so when we do include the weighting, and in this case the regression adjusted approach, we see that indeed the trends are parallel, for the first cohort. And then post-ACC, we see an increase in the fee-for-service expenditure. And that I would have been much happier if I saw instead the ACC declining, but instead the trends of the ACC group was constant. And so if we were to interpret this causally, we would be saying that the ACC group would have followed this trend upwards in the post period. We have no way of actually testing that, and so the approach is more to argue that there were no specific shocks to the fee-for-service group that would not have affected the ACC group, and that we'd expect this natural increase over time. Some of it could be inflation. We're using nominal dollars and not real dollars. But if we go to the children, similar thing. Actually, they look better unadjusted, and with adjustment, they can get much closer. But again, you see the separation, though not as large, but it exists with the children as well.
I have a question. So it looks like you have parallel slopes in the pre-period as you were aiming for, and then it looks like the slopes could be diverging some in the post-period. Is that what you're testing for? Is that difference in difference
Yeah.
slopes in terms of greater slope in the non-ACC, more increase in the non-ACC than in the...
Exactly.
Yeah.
So if we looked at, say, about 1 year post,
Yeah,
we have this difference
right.
between the ACC and the fee-for-service. In the pre-period, it's much smaller. And so you can think of it, this is the initial difference.
Right.
This amount up here, so what's left over is the treatment effect.
Do you adjust for seasonality also?
No. So that would be in the contemporaneous trend. So
Right.
we're assuming that would affect both the fee-for-service and the ACC group the same way. And so actually these graphs, it's not in there because we're just averaging by the quarter. And so that this is affected, but in our full analysis we did control versus previous trends. And this is what it looks like when it doesn't work. So this is with cohort 3, and we see that there's a trend downward in the ACC group. In fact, they were higher at the beginning and then they're lower at the end. Whereas the fee-for-service group was pretty straight or slightly upward sloping. And so we do focus on our cohort 1 results. So yes?
Could you fix that by just doing piecewise linear through those trends?
So what we did is we had group-specific trends, so we added those. And so that in turn lowers the estimate. I just put this in, it's not the true trend, so it looks a little bigger here. But this would imply that there's higher spending than what they would have been in the, without the ACC. And this actually looks like it's about the same. But actually this is a little bit closer. But the cohort 3 results were not significant, right? And so part of that was the actually modeling the group-specific trends, which is a more conservative approach. So we ended up, initially we used primary care provider fixed effects to control for this selection. And then when we got to the full sample, we really didn't need them in there to get those parallel trends in the pre-period. So we're just using a 2-part model. And so this is something used in health economics where notice the fact that you get a very strange distribution of spending. So you have many people with zero spending, and then conditional on any spending, it tends to be very skewed to the right. And so we model these in 2-part. First, looking at the probability of any spending, and then conditional on any, we use a generalized linear model with the log link and the gamma distribution. The log link takes care of the heavy skewness, where a few people have very large expenditures. And we use robust standard errors clustered by the primary care medical provider, the medical home to treat it to. Again, we do a separate one by cohort. And here are our results. And so I've taken these out of the two-part model. There's a big derivative that you take that takes into account both parts and backed out the implied estimates of the change in spending. And these are converted to PMPM basis. So with adults in cohort 1, our estimates suggest that there was a $38 reduction in per member per month spending the first year. And then in the subsequent years, it increased slightly, but it was relatively stable. In children, there was a smaller reduction in the first year, and then a slight increase in the subsequent years. And yeah, this is that in cohort 1. As part of the evaluation, we also looked at differences across RICOs, and we implemented that just by adding our RICO fixed effects and then interacting with the RICO enrolled, taking advantage of the fact that the RICOs are regionally based, so we can have a pre-period where we define the RICO region as well as the post-period. We also looked at variation across practice size, so we interacted our practice size fixed effects with the RICO enrolled treatment effect, and then also examined KPIs and other quality measures. So in summary, we did find that there were reductions in spending that were consistent. Over time, there's a bit of an increase in the later years. Overall, the spending reductions are less than the PMPM payments paid directly to primary care physicians and RICOs directly, but not much. So it's not really a meaningful difference. But it is a decline. And then the results are robust too. I mentioned previously the physician fixed effects. But we also used a restricted control group of folks who didn't enroll before January 2014. I should have mentioned the way the cohorts are set up. In any given period, you could be matched with anyone in fee-for-service, but if they join the RICO as a member of, say, cohort 2 or 3, they're not a candidate for the propensity score specification. So we do have that kind of shifting in and out of the groups when we look at cohorts over time. And so there's a lot we assumed away with that kind of attrition in order to be able to estimate that. And so we are tempered in our conclusions that they are associations, mainly because there is this attrition element that we haven't dealt with. We partially do it with the propensity score, but there may be other things that we can observe that are leading to people to enroll later. So that's a caveat there. And I think it's about time. So I'll just leave it on this conclusion slide. So looking forward to hearing your questions.